Hi everyone, and welcome to the School of Health Information Sciences Health Terminology Standards Seminar Series for June and July. My name's Linda Bird, and I'm one of the instructors for the Health Terminology Standards Certificate Program that this series is a part of. The students of the certificate program have just started their final course, which involves doing a field project of their choice under my guidance. Before we get started today, let's begin with our territory acknowledgement. We acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt and Wasanich peoples whose historical relationships with the land continues to this day. As I said, this seminar series is delivered as part of the final course in our certificate for Health Terminology Standards program. If you're interested in joining the next intake that starts in September, the application deadlines have recently been extended to July 15th. This is a one-year part-time online program with 4 courses done through weekly online evening classes and a virtual workshop. Graduates are eligible for the Certified Terminology Standards Specialist credential from the Canadian College of Health Information Management. So if you're interested, please visit the UVIC's Health Information Sciences certificates page for more information. So today is the first seminar of the Health Terminology Standards seminar series. After today, the rest of the series will be held on Tuesdays at 5 p.m. Pacific time. So next week, we'll be hearing more about nursing data standards in Canada. On June 27th, we'll hear more about what they're doing at Alberta Health Services. On July 4th, there'll be a presentation from SNOMED International. And then the final seminar on July 11th will be on computable care guidelines. Please note that all of these sessions will be recorded and shared on the school's website. And if you have any questions or comments throughout today's session, please use the chat box to type these in, and there will be some time at the end for questions. But today, we're very pleased to have Dr. Morgan Price with us to give a seminar on primary care system improvement. Can standards help? Dr. Price is an associate professor at the University of British Columbia and the associate head of Department of Family Practice. He is part of the BC Primary Care Innovation Support Unit, where he is actively developing tools and methods to support team-based primary and community care. Dr. Price is also an affiliate faculty at the University of Victoria in the Division of Medical Science, in Computer Science, and in Health Information Science. His research areas include action research, design science, user experience, systems and software engineering, and adoption of clinical information systems. And on top of all that, he also practices family medicine in the inner city with underserved populations in Victoria. So with that, I will pass the screen over to Dr. Price for his presentation. Thank you very much.
Great. Thank you so much. You can hear me okay?
Yes.
Perfect. And I will just share my slides because I have some of those. Yeah, so I have a whole bunch of different things. That was quite the intro, so thank you. We're going to talk about can standards help, and I'm going to try to take a lighthearted, somewhat clinical view into this and a little less technical, but hopefully both entertaining and educational at the same time. So I too would like to acknowledge the Lekwungen speaking peoples. I'm here in Victoria and on their territory and lands, and I'm very honored to be in this marvelous space. I've already had a wonderful bio. I will say I still practice a little bit, and I should have added that I am an EMR user of a brand new electronic medical record as of this morning. We, after 20 some odd years, actually just changed our EMR systems at 9 a.m. this morning. And I think I was the first person to be on the live system seeing a real patient. So I may have a few bruises and that was not even post-traumatic stress. It's current traumatic stress of a new system. It actually was okay today. I've been involved in standards as well. So provincially and nationally, and when Canada Health Info was building up some of its standards, and when CAIHA was building some standards, I was involved in some of those committees. So I've had experience at different levels. My basic ground rules for something like this, please interrupt. If you've got questions, I know we said put them in the chat, but also feel free to jump in and ask. I'm more than happy to take questions as I go along, as opposed to trying to remember where we were in the conversation. So steer the conversation where you want it to go. I'm here to share a bit of knowledge and experience. And if you want to steer the conversation in different ways, please do, rather than having me drone on in the wrong direction. Just steer me where you want to go. So today I thought I would talk about a horror story. It's always good to start with a story, right? And then talk about why I think standards are important in practice, and think about it from 6 different contexts, and then have time for discussion, of course. And before I start this horror story, we'll start with a joke, which maybe is a horror story. I don't know. But what is the standard joke about standards? And seeing as I have the very first lecture in this seminar series, I figure I can start and use that joke. So the standard joke about standards is that there's so many standards. Invariably, somebody wants to create a new one. Let me tell you my horror story, which is really interesting to have this. This is an old story, but it is an interesting cycle back to where I am this morning. So I moved to Victoria now 16 years ago, and I was incredibly excited because I was doing health information science work, working in the hospital, building information systems, but the clinical practice I was in primary care actually was still paper-based. So when I moved to Victoria, I was ecstatic because I moved to a practice that had its own electronic record, and we had literally years of data. And there I was. I still had hair, and I was very excited. Well, I had hair for a very short period of time. Here was my first experience. It wasn't great. There was still paper charts floating around. And I looked at the data, and I was that's when I think I lost all my hair. So from my office, here's some examples. And I feel free to share these now because we have literally moved off this EMR, and we've been improving our data for many years now. But in the inner city, we do things like treat substance use, mental health, Hep C, HIV. And when we were looking through our data, here's some examples of some of the data. So for those of you who don't know, hepatitis C is a liver disease. It's a viral infection. And here's some of the codes that were in our EMR. And if you know standards, if you know data, some of these are horrendous because you've got built into the code genotype 2, which is fine. It's a subset. Cirrhosis, so hepatitis C with cirrhosis, is actually 2 separate diagnoses. They're related, but they're 2 separate ones. Hepatitis C PCR positive means that it's a test in there for Hep C. But worse, there's another code in there for PCR negative, which means we've had the world's greatest test, and you don't have it, but it's coded as Hep C. And then we have a couple of dates in there as well, which probably shouldn't be in the code for the entire EMR, so that I could actually code 2001, but I can't code 2002. Here's another set of codes. What I want to point out for everybody is the beauty of our EMR is that we have, we actually using standards, of course. So we have ICD-9 codes in ours, and you'll see those numbers on the right-hand side of the list. So unfortunately, very, very few codes actually had an ICD-9 code. All of those diagnoses of cellulitis in the different locations did not actually code to a number. So it became very hard to track them afterwards, even if you picked the code. Here's a few more for substance use. So heroin addiction, heroin dependency. The bottom one, heroin dependency, is what my wife thinks I have, but it's a completely different kind of heroin, of course. It's a heroin with an E. Going back to hepatitis, we had 34 different hepatitises. So here we have lots of misspellings. We had a hepatitis, and we had hepatitis and hepatitis, which was the classic Greek tragedy, of course, not the viral condition. So, my gosh, right? Just looking at those couple of conditions, all these different challenges with our data set. So, what's going on there? Well, we'll come back to it in a second. Some of the other things, this is early on. I wanted to look at diabetes. Diabetes is a very common condition that we want to be able to do some QI with. I wanted to just ask the question, how many diabetics did I have? And then ask how many had an A1C. So you can look at it in a bunch of different ways in an EMR. And I'm going to use here beyond just the coding now. So let's look at diabetes across a couple of different ways. In primary care, this is fairly easy to do. Most EMRs allow you to do various kinds of searches for your practice. And when we were setting up the requirements for EMR selection in British Columbia, that's absolutely some requirements that we had. So I thought, well, let's look. How many patients have diabetes on their problem list? That should be easy. Certainly easy to search for. We found about 100 patients. Now, our practice at that time was around 4,000, 4,500. That number seems pretty low, but also remember we're in the inner city. So yeah, it was low-ish, but not like, oh my gosh, that should be 5, 6 times higher. It's probably half, 1/3 of what it should be. But then you ask the question, well, what about in billing? Did we ever bill for diabetes? And we did. And we billed a little more frequently than we actually recorded it in the patient's problem list. And then to think about other ways. Well, what else would define diabetes? The diagnosis of me putting on the problem list is one. Me billing for it's probably a second one. What about a fasting blood glucose of greater than 7, which at the time was the diagnostic definition? So using the lab standards and the fact that we ordered the test, could we figure out how many patients? And lo and behold, now we're getting up to about 170. But we may not have ordered that test. And at the time we did the study, hemoglobin A1C tests or A1C tests were only done on patients with diabetes. So we did that one last. And lo and behold, we had about double the number who had an A1C test than those that had diabetes in the problem list. So this just starts to inform the quality of what we were able to do between the standards we had available and how we use them. So really the take-home message here in my horror story is that poor use of existing data standards meant that I really couldn't start doing these cool things I wanted to do and answer the questions we needed to answer in our practice. And by cool, I do mean geeky, because that was one of the things that I was super excited to do, was to start figuring out what could we do for QI and quality improvement in our clinic. So took a step back and wanted to look at the data more holistically. Those were kind of like little snapshots and little windows into the data at the time. We actually extracted all of our diagnostic codes out of the EMR. We had about 10,000, 11,000 of them. And just did a frequency plot based on how many times they were used in the encounter. So every time there's a visit, we should be coding something in our diagnostic assessment fee code. And those are those lists that I showed you at the very beginning. And fascinating just what came out. So this is the graph and also the curve. So the axes, and there's a blue line very close to the edge of the axis, which is actually the plot. So the most frequently used term was HIV. In terms of diagnosis for encounters, it was used over 10,000 times. The second most common code was around 6,000, and it was hepatitis C. And then, as you can see, this very, very steep drop off, and about 500 codes, 543 codes were used more than 50 times over years. This is multiple years of data that I was looking at. 4/5 of the terms were used less than 5 times, and more than half of them were used more than once, or sorry, used only once. Just a staggering drop. In primary care, I think you're going to see this often, that common things are common, and so there's going to be a curve, but that's particularly steep. And part of the reason is, if you understand our practice, the area that we're doing research in, not surprisingly, Hep C and HIV. It's not that that was what we saw the absolute most, but those are the things that we really cared about for our data quality. So people spent time cleaning up and really making sure we coded the right thing. And then after that, things sort of taper off. Even though they might be more common in terms of number of visits, they might not be coded quite as consistently. So we didn't see them as much. Now, in that half that wasn't coded more than once, we had these fascinating things. So we had 150 over 78 sitting. Free text. Only used once. Technically, that I think that's a blood pressure measurement. Sinusitis back paint. I don't know if that's because somebody painted a big red nose on your back. And then he denies any real change in condition. So these are coded. These are not just free text, but they ended up coded into our system. So why do we end up with this bad data? Well, we had a feature called flexibility. So here's hepatitis, the orthopedic liver disease. And if at the time when I joined, if you typed in something that was misspelled, this pop-up window would pop up. And it says, register hepatitis in the problem index. So that's in my master database. And it defaults to yes. And if you press no, it goes through a series of error boxes, or it used to. And you could just imagine anyone who's really busy would just press enter and then enter a second time to default to yes, and then it would be recorded forever. But you'd never know that if you didn't really think about the data from a standards perspective. And now we have this imaginary disease, hepatitis, in our database. When we look nationally, we find hundreds of various shorthands across primary care EMR data. Diabetes, I think we saw, it was 400 different ways of annotating types of diabetes. DM, diabetes, misspelled in 100 different ways. Type 2, non-independent, et cetera, et cetera. So people can do all sorts of fascinating things to the level of hundreds of codes if you're not careful. But why? Why does this happen? It still happens today. I have to say, it's not quite as bad, but it still happens today. And it happens because we ask for it. And I'm allowed to say we as a clinician. We're fast, we're busy, we just want to get the job done. I know what it says when I read it. Just let me type what I need. And the majority of us have been paper trained. Or at least we've been trained nowadays to think about the electronic record more as an electronic paper record, like a Word document or a Google Doc, than a database that we can then use the data in different ways. So we progressed to these flexible standards, and that led to my horror story. And in our brand new EMR that we started using this morning, I was reminded that there's several spots where we have exactly that same kind of issue. The opportunity to put in whatever you'd like. And some places that's really necessary. And some places it's a challenge. So there's my horror story. I'm going to dive in the second part of this and talk about standards and how they can be helpful. But please do interrupt me. I am certainly happy to take questions. I will keep going and carry on through my slides. If people just want to listen, that's fine too. But I will go into the different ways that standards can be helpful, and particularly thinking about sort of my work in the trenches and sort of how it's worked for me over the years. And what I like to think about with data is it is a foundation for all things care and care adjacent. So I'm going to break it down into 6 different areas today. And first, think about the point of care. And some of the stuff I was just talking about is that as well. So let's start with the point of care. So first off, there's multiple levels where this is important. There are terminology standards. We think of, what we use in BC in primary care is still ICD-9. We're a couple generations past that in ICD. And there are other terminology standards that we likely should be using that are better designed for point of care. So there are terminology standards to think about, but then there are structural standards to the information. So it's not just the code, but it's the other components around that code that you might want to track related to it. So diabetes, but also its onset, its severity, those sorts of other pieces that can wrap around a diagnostic code or a lab test or whatever you want to talk about. So there's those more structural standards. Then there's how do you document in general? So we're getting a bit more clinical. What things do you want to record? What are your documentation standards? When you're seeing somebody for a blood pressure check, what are the things you want to do? For diabetes, what are the things you want to do? How do you want to document those? And then you get all the way down to more management continuity, clinical practice guidelines, which should be thought about as a standard as well. They're not a terminology standard. There are several, levels beyond that, but those are important. And they all relate clinically. And I think the challenge is with point of care standards is if we're going to use them, we need to use very detailed standards to have them be clinically relevant, or find some way to wrap those additional structural pieces around the terminology. So, we need detail. Seeing somebody in clinic who has an infection on their left hand affecting the wrist, and the infection goes 2 centimeters up the forearm and there's streaking. Wow, that's a lot of detail. Now, does the the regional manager or the jurisdictional planners need to know that it's 2 centimeters with streaking? Of course not. They barely need to know that it's left hand. They probably just need to know how many cellulitis, how much infection was there, that sort of thing. Even at a local level, when you roll it up, you're going to be rolling it up to kind of that level of infection of cellulitis. But I need that. And the nurse that I'm working with needs to know that 2 centimeters, because if it's now 5 centimeters, that's a big deal clinically. So these things are really important. And unfortunately, to get those details into standards, from a user interface perspective, it gets harder. So there's more work. And that's why people tend to push away from it. Once you get it in, though, there's a lot of things that you can do. You can start to do alerts. You can start to flag things like, oh, well, the cellulitis has changed. It's gotten worse. Let's just flag that for you. I think that's when you start to get into things like SNOMED can start to code left and right hand, et cetera. That's where it gets very potentially powerful for us if we can code it consistently. So point of care, I think, is really, it's where the data often will get collected to start with, and it's one of the harder places to start. And it's often the place you don't see where the challenges are if you're just used to reading your pages. But let's step to the next point, which is shared care. So thinking about shared care, this is still care, but now we're expanding a little bit to that idea of, well, what if I'm working with my nurse? But also, what if I'm working with a specialist down the road, or I'm interfacing with a hospital, or I'm interfacing with a patient in their personal health record? And so it's patients sharing care directly with patients and sharing data. And if the data aren't standardized, then you get all this potential either duplication, or you bury it into other spots in the EMR. And so by that, I mean, if the specialist codes diabetes as diabetes type 2, and I've just coded it simply as diabetes without specifying, even if we code it properly but at a different level, an unsmart electronic record will give me two diagnoses, instead of saying, oh, do you want to upgrade to more precise diagnosis? Or worse, if we're not using codes, then it doesn't know what to do with that. most EMRs today will, at least in BC, a lot of them, if they're going to accept that, will typically accept a consult letter and just put it in as a document and not try to merge. Some of the EMRs that are the same EMR product will actually do some transfer of the codes as well, which is good. But that I think is a real challenge that we haven't worked on well. We've done some work in the lab. My colleague Jens Weber really is the expert here around bidirectional transformation. And I think it's important to think about the round trip. So not just can I send something to the specialist, but what happens when the specialist sends me back a letter? Because then you can sort of see this sort of feedback loop that we don't want to have. So you got to think about it at a full cycle. If you can do it though, the positive of this is when I accept a new patient, I don't have to hand code all that stuff and spend 20 minutes, half an hour putting in a complex history. And then my EMR starts to do all those beautiful things like decision support and alerting and recalls and all those other things that I'm gonna start hinting at in a minute, without all the manual effort, which is huge. That's a huge time waster when you have to redo it all the time, or do it for every new patient, and it'd be a huge time saver if we had it working. The obvious one is billing. No pun intended, but billing requirements are pretty well prescribed. So you know what you have to submit, and the EMRs know how to do that. And we all know that we don't get paid if we don't submit the bills properly. So that in most primary care systems has been where we started. It was built out fairly clearly. They've embedded some data collection into billing that was then used mostly for planning in most places, so most provinces and in the US as well. We use ICD-9, as I mentioned before. Other places are using ICD-10, but they pick the codes for planning, not for clinical care. So we use ICD-9 because of a historical decision in BC to collect those data for administrative purposes, and now we're using it for our clinical purpose. And we end up using it for a whole bunch of things we probably shouldn't, just because it's there, just because we don't have to double enter. And that saves time, but it's not as helpful as it could be. So now we're going to move a little bit further away from care. I'm going to talk about the mythical time of point of reflection. So this is that magical 20 minutes a day that no clinician has, where you think to yourself, oh, how are we doing? What can we improve? Kind of the horror story stuff I shared at the beginning. Like, what can we do for quality improvement? Maybe you go off to an educational event, you get inspired, and you come back and you look for stuff. Or maybe there's a pandemic and you need to start tracking some information. And we did that, actually. I can share this picture because it got onto the news, actually. So it's public. But this is we were tracking an outbreak of COVID in our housing units, and we were then able to extract data and see over time what the trends were and locations, etc. So you can do point of reflection work with the data that you have, and a lot of point of reflection actually comes back down to data quality at the beginning. So are you using the standards? How many patients do you have? That kind of thing that I did at the beginning with how many diabetics, and then how many diabetics according to the labs. And it allows you to be much more proactive in the areas and gaps in your practice, which is really, really valuable. Unfortunately, it can be a lot of high friction work at the beginning. Again, if you've been using an EMR and not thinking about the data. So if you're in an opportunity to help clinicians improve their data, it's a huge benefit, because this is the spot where people get excited again about practice, when they can see, oh, here's a gap, and I can do this small change and have a positive impact on the people that I'm caring for. That's huge. So point of reflection, I think, is a really important place. But unfortunately, like I said, it starts off often with data quality. And we're only recording 1/3 or 1/4 or 1/10 of our diabetic patients properly. We can't start recalling them. to do foot exams, etc. Getting a little further afield, policy. You probably need a little bit less detail for policy development, but it still needs to be relatively accurate. Obviously, there's lots of, leveraging existing data sources here. There's not a lot of direct data collection. Availability of data can be a challenge for all sorts of reasons. Also, that unique differences of how we misspell things can be a problem as well. Different sources, standards in hospital, standards in specialist office, standards in primary care, standards in PHR. If they're not aligned, mapping can be a challenge. So I think that those things are things to consider. But you do tolerate some errors more gracefully, I think, when you're getting up to the policy level, at least a little bit. I think policy development, you probably have a bit more resource compared to the small clinic that might need to do data cleanup. But you are making some big decisions. And those, so gaps can have not just impact on a few patients, but impact on large policy and funding. And then the last category, near and dear to my heart, is research. And research kind of is an interesting one in the sense that we've been sort of going from high detail to less. But actually, for some research, you really do need that very specific level of detail. EMR, using EMRs is really, really attractive, or any electronic data set is really attractive because it's easy to collect if the data quality is good enough. And so you definitely need approaches to cleaning up the data. Now, some of that can be done algorithmically. You can do probabilistic kinds of things and say, well, if there's no diagnosis, but we know A, B, and C, then we're going to assume that that's true. And the CPSIN network, the Canadian Primary Care Sentinel Surveillance Network, so if you're looking for the acronym, it's CPCSSN. The CPSIN network has several validated diagnostic tools using their data. So diagnostic tools, but confirming the diagnosis of patients. So you're able to then, even if the code isn't there for diabetes, congestive heart failure, I think there's about 10 or 12. They have validated these different EMR queries to then confirm a higher likelihood that you have the diagnosis. And so we can use those for research, which is really, really helpful. And then you're not asking the end users to do more data collection, which is great. So very appealing to have those standards in place for research. And then research ideally informs both policy and then can inform that quality improvement and that point of reflection. So there's a feedback loop as well. And then ultimately improving point of care. So I think standards touches all of these. And I think it's very important that we understand which are the right standards and how we can leverage them to make them easy to use. So I've gone a little faster than I thought because we certainly had fewer questions. I'm going to pause there and see if there are questions. I didn't see any pop up in the chat, but see if there's any questions or comments that have come through.